Next on primary care, plastic surgery, what patients should know before going under the knife.
Plastic surgery should be something that enhances what you already have and not change your entire identity or even ethnic background.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health and care of African Americans. Plastic surgery is no longer just about celebrity makeovers or dramatic transformations. Today, it's a growing part of everyday health conversations, from breast reduction that relieves chronic back pain to body contouring after major weight loss. African Americans are seeking cosmetic procedures at higher rates than ever before. Yet, important questions remain about safety, scarring, cultural sensitivity, and access to board-certified physicians. Joining us today is Dr. DeLorean Griffin, an award-winning board-certified plastic surgeon who specializes in personal and cosmetic reconstructive procedures. Our colleague, Dr. Griffin, welcome to the show.
Oh, thanks for having me, Dr. Joe.
Good. Dr. Griffin, primary care gets involved in this sometimes early, and we're doing referring for patients who inquire about specific procedures. But let's face it, primary care doctors aren't very well versed on where the ins and outs are on plastic surgery. So we punt. What do people need to know about the differences between reconstructive and cosmetic procedures that they're seeking?
Well, yes, U.S. primary care providers are involved early, and you guys also provide the clearances for a lot of our surgeries to make sure they're optimized for surgery. Now, the differences between cosmetic and reconstructive surgery is one is medically necessary, one is elective. One tends to be covered by insurance, reconstructive procedures, and your cosmetic procedures are out of pocket for the most part.
Yeah, so the people who have significant weight loss, does the whole concept or the procedures that involve body contouring move from cosmetic to qualify for a change of life type of issue or a functional issue for these patients? Is there some overlap, and how can we move between the two, especially when we start talking about what insurance covers and doesn't cover?
Right, so your massive weight loss patient becomes what we consider as plastic surgeons a hybrid patient. There's part medical necessity in terms of what is covered by insurance, and usually what's covered by insurance is the penniculectomy, which is that lower part of the skin that's overhanging. When you lose the weight, you can get rashes, you can get disruption of
under the arms, but
they don't. The insurance companies typically don't consider the arms and the thighs and everything else, but they will consider the pannus, and because of that, you have trouble using the bathroom, and just quality of life is disrupted because of that. So you usually have to document that you have a significant amount of overhang, have rashes, and have lost a certain amount of weight before you qualify for that. Now, I say that they're hybrid patients because oftentimes we're doing contouring with that. We care about the aesthetics of it as well. Me personally, I don't just do penniculectomy, I do a full tummy tuck. Moving the belly button, doing a muscle repair, contouring with liposuction and everything, just so they get the whole package.
How much, I know we're clearing these patients for surgery, but how much does pre-existing conditions play into this? The high blood pressure, the diabetes, the smoking even in patients like this. How far do we get into that in terms of counseling patients ahead of time or optimizing them for surgery?
Right, so at the end of the day, plastic surgery is elective. Nobody really needs to have plastic surgery, even in the reconstructive cases. However, we want to be able to address those modifiable risk factors, and especially like the smoking. You got to stop smoking. So for me, I have patients, they got to stop smoking for 3 weeks before and 3 weeks after. We can't control the after, but beforehand, I even test them, and I'll cancel the surgery if they test positive for nicotine on the cotinine test. So it's very important. The things like diabetes, making sure the glycemic index is within range, and hemoglobin A1C is like 7 or less, and their blood pressure is under control. So we send everybody for a PCP evaluation when they're getting major surgery and making sure that their risk factors are minimized. You can have these things, we just got to minimize them because ultimately it does affect how the postoperative results.
Recently, the last decade, maybe longer now, we've just seen this uptick in the patient's interest in cosmetic surgery for lots of reasons. I mean, we have information overload in this society. People are seeing all kinds of things, reality TV, the whole 9 yards, and it leads to people saying, is there something that can be done to change my appearance? In the African American community, it seems to be more so than I've ever seen it before. Do you attribute that to any particular factors?
Yeah, definitely driven by social media and the digital age, and kind of creating this whole fantasy world sometimes that we see online, and having unrealistic expectations. So we as a plastic surgeons, we got to level set expectations with our patients and make sure that, you know, people will come to us with wish pictures that are kind of unrealistic, and we got to, again, bring them back to a place where we can say, well, this is the result we can get in you. Mm-hmm. You know, we're going to improve your appearance, but mm-hmm. this is what we can achieve in your particular case based on your body structure, bone structure, skin type, mm-hmm. you know, even the amount of fat, the type of fat that you have.
Right, so there are some realistic expectations that people should be aware of.
Absolutely.
So in the old days, it used to be a nose job and some eyelid work, and that was, you know, pretty much the extent of it. But now we're getting into a phase of congruent ethnic type of surgery, which is becoming more common, and people ask for it more. Help our viewing audience understand what that actually means, and why is it preserving a person's identity is so important in this field.
Right. So, you know, plastic surgery is always evolving, and technology is always changing, and kind of trends will drive a lot of what and how we do it. And African Americans in particular, I would say that it's very important to maintain that. You know, we've all seen, you know, the Michael Jackson, yes. LaToya Jackson, kind of have that nose, and they've had 17 nose jobs, and that gets into body dysmorphia and whatever have you. But ultimately, plastic surgery should be something that enhances what you already have and not change your entire identity or even ethnic background or ethnic features, mm-hmm. so to speak. Mm-hmm. So I think ethnocentric, like rhinoplasty, for mm-hmm. you know, a lot of women have a broad base nose and they just want to contour the tip. You know, sometimes African American women have like a bulbous tip mm-hmm. That they want to just slim. And it's just important to not go overboard with that.
So we're seeing some people interested in particular things, of course, but breast reduction, breast enhancement, liposuction, gluteal enhancement, or BBL.
Brazilian butt lift.
All of those are things that, you know, years ago it was not a discussion.
Right. So again, it's driven by social media. I think that, you know, if we're going to tailor this to African American, you know, breast reduction is medically necessary. It's for back pain, but again, we still care about aesthetics. Breast augmentation has been a thing forever. Mm-hmm. You know, women have gone from the triple Gs, and now I think the trend is going with smaller implants or doing no implant at all, just doing a lift with some modifications, either some fat grafting or using their own tissue too. So a lot of women, you know, are opting not, either taking out their implants or not going with implants in the first place, because there's been this whole stigma with, you know, do the breast implants make the patient sick over time? And there's some evidence to that. And so the trend has been to either go smaller or opt for not an implant at all.
I remember early on in my fellowship, from a lung standpoint of view, we saw a few dozen patients who had implants of various types for breasts, and it was causing lung dysfunction in terms of the quality and the type of material that they were using. We don't see that much more because I think we've graduated from that stage to one that is safer for women seeking that kind of service. Mentioning that, we're seeing a trend across the country. People are seeking services outside of the United States. Mm-hmm. I recently saw a patient who returned from the Dominican Republic mm-hmm. and had complications for a particular procedure. What has been your experience?
Yeah, my experience with medical tourism in general, and I think the players are usually the Dominican Republic, Colombia sometimes, Mexico sometimes. So I think it's important to, if you're gonna, opt to go out of the country for surgery, definitely do your research the doctor. Ultimately, these other countries don't have the same safety regulations that we have here in the United States, and that's why you see the larger number of complications. I think that in terms of like liposuction, they don't have any liposuction limits there. You can only take off 4 to 5 liters here in the United States. So you get a lot of fluid shifts, you get a lot of dehydration and cardiovascular collapse that can happen. You got bacteria that's indigent to that location. Mycobacterium in particular is a very difficult bacteria to treat, and you got to bring out the big guns in terms of antibiotics, and it's really a problem. They do great work over there. And it's cheaper. We can't combat that. So I say if you're gonna opt to go out of the country, just do your research, get in one of these surgery groups, get as much information as you can. You're still kind of rolling the dice because you come back to the United States and you have a complication, you might have a hard time finding a doctor to treat that complication.
Yeah, it's kind of hard to come behind somebody's work in a lot of aspects of healthcare. But here again, that's a very important directive for patients. Do your homework, especially talking to other people who possibly have experienced that and find out what their outcomes were. That's a great point. Griff, we got to take a quick break here. We'll be right back with Dr. DeLorean Griffin.
Substance use disorder and addiction is so isolating. And so, as a Black woman in recovery, hope must be loud. It grows louder when you ask for help and you're vulnerable. It is the thread that lets you know that no matter what happens, you will be okay.
Even the mighty might not see it coming. It's prediabetes, and it captures 1 in 3 adults. But you can escape. Take the 1-minute prediabetes risk test to know where you stand and prevent or delay type 2 diabetes. Be your own hero on smartphones everywhere at doihaveprediabetes.org.
Welcome back. We're here with Dr. DeLorean Griffin of Griffin Plastic Surgery, continuing our discussion on this exciting and popular topic of all the things associated with plastic surgery that we deal with right now. Dr. Griffin, when a patient returns from a procedure that they've had done outside of the United States, how important is the follow-up and looking for potential complications and handling those complications when they arrive? Should these people be having the direct connect again with a primary care provider?
Yeah, before and after, because again, there's going to be some hesitation from anybody coming behind somebody's work, especially when they've gone out of the country, because there's a lot of liability in that respect. But from a primary care standpoint, I would thoroughly recommend, checking the labs. A lot of these things, again, the amount of blood loss that you could lose in these countries can be quite astronomical. And so I think follow up and getting a CBC, comprehensive, workup before and after, because again, the complication rate could be quite high.
Black skin can be unique in a lot of instances, and we're always concerned about the development of scars and the development of keloids. Are African Americans predisposed, prone in these conditions to those types of issues?
Yeah, more so than other races. You can see keloids in any race, but most prevalent in African Americans, and the reason why is because of the type of collagen. We all say black don't crack, and that's because we as African Americans have more collagen, type 3 collagen in our skin, which gives us a useful appearance. But when you have proliferation of that, that's when you get a keloid. So now it's important to define a keloid. A keloid is a scar that grows outside the margin of the original scar. And people oftentimes get that confused with a hypertrophic scar a widened scar, or even a discolored scar or hyperpigmented scar. So all these are different things. I think African Americans are prone to all of them, but I think there's some misnomers. A lot of times patients think they're keloid when they actually don't, you know. So the specific, you know, criteria that needs to be met to define it as a keloid.
Are there any drawbacks or restrictions into resecting a keloid?
My approach to keloid is, again, you present with it the first time, excise it, then inject. I use dexamethasone. African Americans, a lot of people, we use Kenalog, but that's a precipitate, so that will cause hypopigmentation a lot of times. So I use dexamethasone, which, you know, maintains the pigment. But that will decrease your risk of keloids about 15%. Ultimately, if it comes back after that, we'll do excision again, injection, and low dose radiation 3 days post-operatively, and that will decrease the chance of it coming back to about 15%. So 75 to 85% reduction in.
Okay. And is this radiation done in office?
No, I actually send them to a radiation oncologist,
Okay.
the same radiation oncologist that would, you know, treat a cancer.
Okay. So these procedures and even injections sometimes will produce hyper and hypopigmentation. What are some of the drawbacks in terms of using things? You mentioned Kenalog not being the go-to drug in a situation like this.
Yeah, you know, a lot of people that aren't used to treating our type of skin have, I'm not gonna say disregard for, they just don't have the knowledge that you could use dexamethasone and you get the same effect without it being a precipitate causing that hypopigmentation. It almost makes you look like you have vitiligo at times, so which can be permanent.
Right, so you can minimize the risk of either of these two results just by assessing the patient properly ahead of time.
Yeah, it's just about medical knowledge about, you know, darker skin that we call like Fitzpatrick types, 5 and 6.
6, yeah. Okay, very interesting. So, would you expect any increase in postoperative complications based on ethnicity at all?
Not based off of ethnicity. I think scarring is the most important one. Is the biggest one. I think in general, it's the health status. I think, again, going back to the modifiable risk factors, and then, you know, the things that you can't modify or just modulate, like the glycemic index, you just minimize it. Because the diabetic patients, I've seen a lot of complications in patients that have lupus, either from the disease itself or from the medication that they take. So those immunomodulators can affect the wound healing process. So
proper assessment, of course, and medication reconciliation, identification.
Absolutely.
All of the things in conjunction with a primary care physician seem to be very important, especially in subgroups of patients.
Yeah, they're paramount.
Okay. Talk to us a little bit about non-surgical treatments that people often ask about, and I punt. I say, go see Dr. Griffin and talk to him about it.
Yeah, and our practice is kind of entering this phase to where we are doing more and more minimally invasive things in the office. A lot of patients have apprehension to general anesthesia, and there's a lot you can achieve in the office in terms of sedating the patient, numbing them, without having to go under any type of general anesthesia. We even use Pronox, which is a nitric oxide laughing gas that really takes the edge off. So we do a lot of skin tightening. We just bought 2 new devices and in the process of purchasing a 3rd device to tighten skin, treat the scars. If you look on my Instagram, I just treated a keloid scar and softened it up with the Morpheus, which is microneedling plus radio frequency heat. So we do a lot of that tightening for the face, eyelids, and certainly the body. It's a lot you can do in the office.
For the most part, in times past at least, plastic surgery was focused on females, you know, and many men did not enter into that arena in terms of having a substantial change in how they look. What's happening with the interest from men now in plastic surgery? As a matter of fact, we just did the Olympics. There was a little blurb on what was going on in the Olympics about men in plastic surgery. And I'm saying that's interesting. It's not just an interest in this country, it's an interest all over the world. Are men looking at this from a different aspect now?
They are, and I think the vast majority of my patients, of course, are women, but there's certainly been an increase in interest in men with plastic surgery. I mean, Not only because men are doing the same weight loss with this, bariatric surgery and GLP-1s and having that extra skin, having it around their chest. So I do a fair amount of tummy tucks in men. We do ab sculpting in men. We do gynecomastia surgery in men, either from adolescent or from weight loss or combination of both. So, we do like breast reductions in men. So certainly an increase. Men aren't so driven as women are, but we like to look good and feel good as well. So
absolutely, that's interesting. Maybe I'll make an appointment. And so as things happen in a society like this, we see a lot of spas popping up. They are offering all kinds of things to patients. We were traveling a week ago on a street locally here in the suburbs, and we saw I won't name it, but we saw 4 plastic surgeons' office within a 2-block span in terms of choices that people have to seek this stuff. And in addition to that, if you pay close enough attention, you'll see that in this community, we have non-physician providers doing stuff that folks probably should be aware of, especially when it comes to Botox.
Right. Again, that goes back to doing your research. A lot of these, there are a lot of unorthodox med spas, so to speak, not a lot of unlicensed places. I think Florida is rampant with them. The regulatory environment of Michigan is a little bit better, but you do have people, you have nurse practitioners doing a lot of these things under no supervision, which is completely legal. You have you as a primary care provider can do plastic surgery in your office.
Right.
There's nothing that says that you can call yourself
or
a cosmetic surgeon.
Take a quickie weekend course in Florida,
right,
and come home and hold yourself out as somebody offering this as a service to the general population.
All perfectly legal, but the quality that you're going to get, the follow-up that you're going to get, the expertise is not going to quite be on par with a board-certified plastic surgeon.
Right. There's a standard difference, especially in terms of experience. We really should be looking at what the experience, the body of knowledge for the individual that you're dealing with, especially in sensitive areas like this. What kind of outcomes have you had? You at a talk not too long ago, you showed us some gorgeous pictures of the quality of the work and the satisfied customer behind all of this. I think these are almost just as important as taking a blood pressure on a patient, for them to be aware of that kind of stuff before they consent to a procedure.
Yeah, so you want to look at these things when selecting a doctor. Are they board certified or at least board eligible? Were they trained in an accredited program? Did they do, a full fellowship and not one of these, like you said, weekend courses? Because there's a lot of ambiguity and a lot of confusion on what's a cosmetic surgeon versus what's a plastic surgeon, all of these things. So you want to know if they have hospital privileges, complication rates, how many of these have you done, certainly their malpractice history, and all these things are, factors.
Right.
Doesn't qualify you as a good doctor, but they lead you in the right direction.
Right. You mentioned training briefly. Comment on the status of where we are in terms of African Americans in fellowship admission, successful completion out here in the community, because you guys can be hard to find.
Yeah, so I think there's probably anywhere from 200 to 220, I believe, Black plastic surgeons in the whole country. And
the entire country?
In the whole country, yeah. So it's about 2 to 4% of total. So we're definitely underrepresented, just like we are in almost every field. However, I think we have some initiatives. I'm a part of the Arthur Garn Society, which is an African American society for plastic surgeons. And we do a lot of mentoring, a lot of guidance for students interested in plastic surgery. Those are in medical school or even in residency that are looking for, you know, future employment or just guidance in the exciting field of plastic surgery.
I understand you just had a presentation recently at Wayne State University Medical School
I did, yeah.
concerning these kinds of issues.
Yeah, so I did a presentation for the plastic surgery interest group, and there were several African Americans in that. I think about 3 or 4 in that session. And so we were talking about just what we're talking about here, and showed a lot of pictures, a lot of exciting before and afters.
Right. So basically the questions are endless in this arena, but here again, Dr. Griffin, thank you so much for joining us on the program today.
Thanks for having me.
It's been a pleasure. We appreciate it.
Anytime, my pleasure.
Excellent. Our guest today has been Dr. DeLorean Griffin of Griffin Plastic Surgery. Plastic surgery isn't about changing how you look. It's about understanding how procedure affects your body, your recovery, and your long-term health. Thank you for watching Primary Care. I'm Dr. Lonnie Joe.